I want to introduce something that's called the Neurofeedback Advocacy Project, and my subtitle is How a Good Idea Got Completely Out of Hand. And, okay, so it's the right arrow. Okay, let me introduce myself. I'm Matt Fleischman, and I'm a licensed psychologist in Eugene, Oregon. And I'm the director of the Neurofeedback Advocacy Project, and I have been doing neurofeedback for 35 plus years. As a clinician, I've used it continually in my private practice. I was also a trainer and a researcher. I'll claim being a researcher since I have one publication and another one coming out in neurofeedback. I have other publications in an earlier life. My background was in treating children with behavior disorders, and stumbled onto neurofeedback by going to a workshop actually at the Menninger Foundation. There was a gentleman who mentioned, and I went in to hear a man named Eugene Peniston teach. I won't go into anything beyond this, but there are two founders of neurofeedback, I think, who deserve recognition. One is Barry Sturman. People may know his name. If you want to go to our website, there's some history of neurofeedback. This was the man with the cats. But the other man was Gene Peniston, and I'll mention him simply because he was African American. He was a psychologist, and so one of the two founders in this field. Amazing man, and demonstrated the profound impact this had on the treatment of substance abuse and PTSD. He did this with solid research back in the 1970s. And he's almost unknown. I had to look for a photograph of him, and I wanted to present, and the best we could find was one photograph when he was a guidance counselor before he went on to become a PhD psychologist. So I think part of this talk also has to do with the social justice of helping people and neurofeedback, and I want to put that out as I move on. So it started with a simple idea. I've been doing this for a long time. I am not a creator of this. Everything I have that I do was created by other people. But I wanted to demonstrate the effect of neurofeedback within agencies working with the underserved. Now, I don't know who this audience is, but the foot soldiers of mental health work in public agencies and nonprofits. These are the people who work often. Thank you. Often at much lower wages, and a current trend is they are all being poached by better paying agencies out of these agencies. But these are the people who work with the hardest to serve and the underserved. And so why did I have this project? I started this. And one was, driven by trauma, the demand for services is huge in this country. Nobody is unemployed in this audience, I'm sure. The efficacy of current services is lacking. That's not critical. This field has started. We knew little about the brain, little about helping people, but we are nowhere near as good as we need to be. And the path for developing better services is not working. We are nowhere near as good as we need to be at publications. I won't go into the details. But our current mental health care system prioritizes medications first and talk therapy second. And that is not a solution to the problems that we have. And even though we talk about the brain endlessly fascinated, there is very little appreciation, actually outside this room, of the power of non-invasive, non-verbal treatments that address the impact of trauma. Trauma changes the brain, and yet very little of what we do addresses the brain. So why do this? One is, I knew that neurofeedback worked with clients who do not do well with current mental health care. Especially at those with a history of developmental trauma. And, two seminal books. I don't need to tell anybody in this room about The Body Keeps the Score. It has been on the top 10 bestseller list of the New York Times for 2 years. Congratulations, Bessel. He has to be a wealthy, wealthy man for this. So that's an amazing 2 years on the bestseller list. And Also, I hope everybody here has read Seaburn's book, the first book. It's excellent and with a much more focus on neurofeedback. But we have two fabulous books. But I've been frustrated that neurofeedback, to the degree it's out there, is mostly in the fee-for-service settings. And it's not reaching the people who need it. And when people get quoted about neurofeedback, they disparage it as, well, it could cost $2,000, $3,000, $4,000. You know, not to look at the cost of psychopharmacology in this country is outrageous. But since I can't bring down that cost, how do I get it out into people who otherwise need it and can't pay those monies because they can't? So it started with a simple plan. There I was, sort of winding to the end of my clinical career. That's me on the left. And I thought, why don't I just demonstrate that this will work? And I'm in Eugene, and I said, let me go to 3 local agencies to try neurofeedback. And here was the deal. I would let them use my equipment, because I had built up a practice, if they would go for the training and pay for the training. And so 3 different groups agreed. They would fly down to Los Angeles at the time. That's where the training was held. But I would do one thing different than anybody else had done. I would track the results. Because if I had the data, I could put the data out there. And that's one problem with research, is that researchers do studies. Who holds on to the data they do, and eventually it shows up in some publication that nobody reads. So I was going to do it differently. And what were the 3 agencies? One was a community mental health agency serving clients on the Oregon Health Plan. That's Medicaid. So they were all Medicaid clients. The second was a county behavioral health department's forensic unit. So these are men and women sentenced to therapy in lieu of prison. Basically, a lot of them were on the spectrum, but not all, bipolar disorders, whatever. But basically, the court in each case recognized that these were not crimes that people had thought out to go commit. They were the crimes that mentally ill people create. And I'm sorry, I'm just going to throw the term out, mentally ill, whatever, because of poor judgment and impulse control. And so they were remanded. You go to therapy, you take your medication, we won't lock you up. And the third was a program for male and female felons just released from prison. A wonderful program in our town, 60 to 90 days transitional housing, job support. They have all sorts of counseling. And we said, well, okay, neurofeedback, we'll do it too. But I said that in doing this, I also wanted to track the results, because I know there are 2,400 publications. None of them convince me. That's not to say, because the results that convince people, I do not believe are the results that the researchers publish. And so I thought about this and I said, if we're going to do this, I want to be convinced if I was the person looking at the results. And what would convince me of the results? And so I said that one of the results, the key is the results have to be client-centered. When you go to the doctor, physical doctor, and you say, Doc, I got a problem, the doctor first is going to ask you, what's your problem? And you're going to tell him, oh, I got an ache here, a pain here, I've got a headache here, I'm bleeding here, whatever, whatever, whatever. The doctor wants to know from your perspective what the problem is. Now, that doctor will then render that into some diagnosis, but he's still talking about your problems. You go into a psychotherapist, and the psychotherapist says, what are you here for? And you say, and pretty soon it's about your relationship with your mother. You didn't go in for the relationship with your mother. But in this field, it is very hard to track back to what you think is the problem. The other thing is the results have to be meaningful. In other words, oh, that changed. Ah, I understand. So, for tracking what is client-centered, client-selected, and easy to understand, I built a system around asking a very simple question. What are 5 to 8 things you would like to see get better if you do neurofeedback? And, you know, what do people tell you? And one is we have long lists of what can go problems that people have. I don't sleep so well. I'm impatient. I fly off the handle. I can't concentrate. I can't focus. I'm too nervous. I hear voices. My feet hurt. My back hurts, whatever. We have a long list of physiological IBS symptoms. My stomach hurts when I'm tense, these sort of things. And, we show people these lists. They check them off just in case they can't remember what else is wrong with them. And then out of that, we say, come up with, okay, which are the 5 to 8 that really matter to you? And the most, I'll show you what the most common ones, no surprise, sleep, anxiety, depression, but, that's what people come in for. And then we ask them on a 0 to 10 scale. This is really profound, right? 0 to 10 scale, how bad is it on a bad week? How bad is it on a good week? And how bad is it on a usual week? And they make these little marks, and I'll show you. And then at every session that they come back, we ask them on that same 5 to 8 things, how you doing? That's it. This is really profound here. And to get a measure of improvement, we're very simple. We average out that baseline of good, bad, and usual to the ratings at the end of the last 3 sessions, because numbers can jump around. We didn't want to pick the last session, but we figured, okay, we'll take the last 3. And versus this baseline. And the reason we do this baseline like this is that, in psychotherapy, people come in, they want to be treated starting today. You can't say, well, let's come in for 10 sessions and we'll get baseline ratings and then we'll do the intervention. So that's, how we did it. And this is what the form looks like. Basically, we created this online using Google Sheets. So if you look at it, you can kind of see the hidden trace of Google Sheets. But one nice thing about Google and Google Sheets is they're HIPAA compliant if done correctly. And so we created this system. I say, up to this point, me and my programmer in Croatia, I've got a, but that's basically it. They call up the screen. That's what the screen looks like. You tap or you check. You can do it on an iPad or you could do it on your phone, but phones don't work. But iPads will work, but your computer works great. And you can see, so for this client, written across the top if you can, they put down sleep, impulse control, mood, muscle tension, obsessive worries, anger, depression, anxiety. And each session they come and they check off. And if you notice this, if the numbers drift down towards the left, they're getting better. If they drift to the right, they're getting worse. Okay. So that's the client-centered part. Let's talk about what is meaningful. So one of the things that's meaningful is, for example, and there's no particular order on this slide, hospitalizations. Does neurofeedback affect hospitalizations? Now, why do we ask about hospitalizations and ER use, emergency room use? It's because the agencies told us that's what the insurers care about. They don't care whether you feel better. That's not their job. They care whether they have to pay for you to go to the ER or the hospital. So why don't we ask? We asked about medication. Does neurofeedback impact the taking of medication? We asked about disciplinary actions in schools. If you got a kid, how often are you being called in to talk with the principal or the vice principal about trouble? We asked about arrests and incarcerations, drug and alcohol relapses. For cognitive functioning, we actually have a neuropsychological test. It's a video game that something flashes on us. It's like a TOVA or IVA. It's a computerized performance test. We use one called the Quick, and I describe it to kids as it's the world's worst video game. And we also asked people how well they cope with stress. We asked about nicotine and also about medical marijuana. In Oregon, medical marijuana has been legal for a long time. I see now it's legal here. We didn't want to ask about illicit drugs, but we could ask about licit drugs. And then we also asked for ratings, therapist ratings and reviews, just like on Amazon. How many stars would you give it? And also, one other thing, we asked about suicidal ideation and self-harm. It's not on this slide, but we asked, you can ask these things of people, and this is what is, I think, meaningful. We also wanted measures of client difficulty, because if when you see psychotherapy results, you never know really how difficult the clients are. So how do we know what's difficult? Well, one is, we gave them an ACEs checklist, Adverse Childhood Checklist. I think everybody in this room should know about ACEs. So we got the average number of ACEs scores. We also asked about concurrent psychosocial stresses. So the DSM-5 has 10. They have 9. They have them also I don't know, these people don't talk to people. So we have a slightly revised version, but it maps very closely. One thing is, it never asked about chronic illness as a stressor. They talk about access to health care. Your biggest stressor is you can't get in to see your doctor. No, your biggest stressor is you're very sick. But the purpose is there. But, excuse my, I don't know, lack of humility, but I sometimes think that people who study mental health don't actually spend much time talking with people who come in. So if you see some changes in what we did, it's simply, come on, folks, think about this. And then we asked about co-occurring disorders. And a lot of clinicians are not legally entitled to diagnose, which is really an advantage, but they are willing to say the person has problems with depression or anxiety or focus or attention. So, we have this based on what the client picked. Okay. And then cost-benefit. One of the biggest costs in mental health is no-show rates and late cancellations. And if you work in an agency that works with the underserved, guess what the no-show rates typically are? And I was surprised, 35 to 40%. Car won't start. 11 minutes? 1. Oh my God. Okay, then I'm going to move real quickly. Did I really? Oh, I didn't. I'm sorry. This is what we got. 38% reduction in the severity. A 54% reduction in self-harm. A 67% reduction in disciplinary actions. 100% reduction in drug and alcohol relapses. 68% reduction in ER visits. 81% reduction in psychiatric visits to the ER, psychiatric, self-harm mostly. 75% reduction in hospitalization and 100% reduction in psychiatric. Okay. Clients rated neurofeedback as more helpful than counseling or medication. They reported 43% improvement in stress management, a no-show rate of 2%, and a premature termination rate of 14% versus 20 to 70%. So I'm going to stop. This is, and if you'll go to our website, because we publish every session, every day goes up there. We are over 300 clients to 20 sessions. All of this therapy was done by line-level agency workers working in over 20 agencies around the country. So this is not a pilot study in the sense of tiny. Here's the last piece. I'm here to recruit you. If you work with the underserved, agency, government, or we'll take consortiums of private practitioners, and I've got a team of people, what we offer is low-cost training, low-cost supervision, and access to this equipment for you to get this out here. That's what the Neurofeedback Advocacy Project is about. So people in my group, would you please wave your hands, because we got people who are handing stuff out. We want you. This is Uncle Sam wants you. I'm sorry I misjudged my time, but thank you.